Good evening, one and all. Today, this weekly webinar of Chest Council of India, we are going to discuss on a very interesting topic, that is air travel and pulmonary issues. As you know, the air travel is very much common nowadays. Means I think everybody in India, especially every middle class people, they are flying with the flight, and the use of buses and trains is slightly reduced as compared to the flight. And in this scenario, we should know about the what are the risks involved for our patient. Especially respiratory patients are prone for the complications with the air travel if they are having some severe illnesses. To this topic for discussion, we have the excellent panel from Pan India. Most important, we have a teacher, Professor SK Chhabra sir from Delhi. He's an ex-professor, director of pulmonary medicine, VPCI, University of Delhi, and currently he is currently chairman of the pulmonary medicine department, Primus Hospital, New Delhi. And second panelist, we have Dr. Apar Jindal. He's a clinical director, lung transplant, Department of Interventional Pulmonology and Lung Transplant, MGM Healthcare, Chennai. Welcome you. We have third panelist, Dr. Keerat Sibia. She is a consultant pulmonology and critical care, SPS Hospitals, Ludhiana from Punjab. And we have two debutants, Dr. Narendra Kumar from consultant Sunrise Hospital, Siddipet, Telangana. And from Gujarat, from east part of India, west part of India, we have Dr. Jainam Navadiya. He's a consultant pulmonologist in Sri Bajrang Das Bappa Arogyadham Hospital, Bhavnagar, Gujarat. I welcome all the panelists, and first of all, we'll go ahead with the what are the common physiological changes in normal persons and with the pulmonary issues patient, physiological changes related to the air travel uh, from Dr. Professor SK Chhabra sir. Over to SK Chhabra sir for the initial talk.
Thank you, Dr. Chandrakant, for this nice introduction. As you remarked, today's topic is extremely important and something which we as practitioners of pulmonology sometimes don't even realize. Almost everyone travels by air or has traveled by air, and somehow we never even think that things up there, the atmosphere up there is different from what it is there at sea level. So we all travel, we go up, we are very comfortable, and we don't realize that it is a different atmosphere that we are breathing in. So, and like you said, maybe a normal person doesn't even realize this, but a person who has got a chest disease, especially who is on the edge, of a health and respiratory failure, for him it can be critical, and sometimes huge problems occur. And most patients don't realize that they may have increase in their illness or some other complications. And even airlines don't mandate a declaration from anyone that do you have a respiratory disease or not. Even COVID times, this declaration has become important. Do you have COVID certification or do you have COVID symptoms? But to the best of my knowledge, this information is not required to be declared when you book a ticket, whether you have got a respiratory disease or not. Only if the person himself volunteers that I want a wheelchair access or special service in the flight, only then it is given. So aircraft do have provision for these services. And if a pulmonologist feels that a person may require these services, then they should be declared and help taken. Now, I'm not making a formal presentation, just a few points to set the ball rolling. So I've just jotted down a few points. I'll take help of these. I was going through data of air travel. Last year, in 2022, 125 lakh people traveled by air. I read in the BTS guidelines that medical emergencies, the major medical emergencies, which would include stroke, MI, cardiac arrest, respiratory, these are incidences 1 in 30,000. So, bit of maths. If we take 125 lakh Indians traveling by air, then there should be 416 major episodes per year, and 50 of these would be respiratory. Now, this would be a gross underestimation. Like I said, people don't even declare that they have got a respiratory problem, and they just go through the flight. Maybe the flights within the country are of shorter duration, so they don't realize. But clearly, it can be very significant. And why in-flight emergencies are important? Firstly, the flight diversions which may be required. You all would have seen a movie Three Idiots. There, one of the actors faints and illness, a cardiac illness, falls on the aisle, and the flight returns back to the air. So that involves a lot of costs, a lot of inconvenience to the patient, and resetting of the whole airport system. The crew is not trained to handle emergencies, and they don't have much equipment also to handle these emergencies. Some of these emergencies can be fatal, and certainly these cause a lot of suffering. So these are clearly important, and these are preventable. So that is the objective of today's seminar. So why things are different up there in the atmosphere, in the aircraft, compared to what we breathe at sea level? A bit of physics and physiology. See, when we are at sea level, our atmospheric pressure that we are subjected to is 760 millimeters, and FiO2 is 21%. Right? That is a fraction of inspired oxygen that we breathe. As we ascend, go up, I'm talking of not in the aircraft, as we ascend, then atmospheric pressure falls in a logarithmic fashion. That is, initially it falls more steeply, and after about 20,000 feet, it falls less steeply. Now, Mount Everest, that is the highest point in land. So the height of Mount Everest is 29,029 feet. And can you imagine what is the atmospheric pressure on the apex? The peak of Mount Everest is 235 millimeters, only 235. And we are breathing at 760. And what is the FiO2 at Mount Everest? Same, 0.21%. So it is the pressure that changes, not the FiO2. That is very important to realize. When we read physiology, especially critical care medicine, then there's an equation called alveolar gas equation. That is one of the most important equations in critical care medicine that allows us to calculate alveolar, the capital A, oxygen. So that uses the atmospheric term Pb minus PH2O into FiO2, and you subtract carbon dioxide pressure divided by respiratory quotient. To just make matter simpler, the alveolar oxygen is directly proportional to atmospheric pressure. And alveolar oxygen, the capital A, what is the purpose? It provides the pressure gradient for arterial oxygen. Gas transfer occurs from alveolus to the pulmonary capillaries, which bring the deoxygenated blood. So that A difference, that depends on the gradient. So as we go up, the alveolar oxygen becomes low. Interesting study on Mount Everest. The PaO2 on Mount Everest is only 25 millimeters. 25 millimeters. And normal PaO2 that we have in health is 90 plus. Respiratory failure begins less than 60. So everybody who goes to Mount Everest develops severe respiratory failure. Physiologically develops severe respiratory failure. So that is why oxygen is required. And I marvel at some of the climbers who have climbed to Mount Everest without oxygen. Tremendous physical ability. Now aircrafts, they cruise at even higher altitudes, 32,000, 35,000. That is even higher than Mount Everest. So pressure inside an aircraft would be even lesser. So if we travel in an aircraft which is not modified, then we cannot travel. Everybody will die in the air. Why aircraft cruise at 32,000, 35,000? Why not at a lower altitude? The reason is at lower altitude there's so much turbulence that it will knock out everybody. So they have to fly at 32,000, 35,000. So aircrafts therefore are pressurized. That is, they increase the pressure inside the aircraft so that it is higher than what is the pressure outside at 32,000. Now aircraft cannot be fully pressurized to sea level. So what we get in an aircraft is an atmosphere which simulates a height of 8,000 feet. That is international regulation, and that is what is the usual pressure. And the atmospheric pressure is around 550-600 millimeters in the aircraft, modern aircraft, which is pressurized. So now one can calculate again from the alveolar gas equation that alveolar oxygen therefore will be less even in a normal person in the air. So humans fortunately can breathe at this level. Many of the hill stations like Shimla has a height of around 6,500, 7,000 feet. What is the normal PaO2 of inhabitants of Shimla? It is only 70 millimeters. Right? So this textbook figure of 90, 100 is only at sea level. But people, normal inhabitants at Shimla, they're able to tolerate. So human body can tolerate pressures as low as 70 millimeters without any adverse effects. So in an aircraft, we are exposed to similar pressures as normal inhabitants of Shimla. Therefore, healthy persons do not get any problem. If we breathe FiO2 of 15%, it will give this kind of PaO. So breathing in an aircraft for a healthy person is like breathing 15% FiO2 at sea level. What does hypoxemia do? It stimulates ventilation. It will increase the respiratory rate, it will increase tidal volume. But that only starts when PO2 becomes less than 60 meters. So that is how we define respiratory. So at a PaO2 70, which we will reach. Now next time if we travel, we should check our own oxygen saturation. We'll come down to 92, 91. But fortunately, it does not go into the respiratory range. But for patients of respiratory disease, things are different. Patients with chronic respiratory disease who have got severe disease, which has utilized the entire reserve of the lung, and now they are close to respiratory failure. So where the saturation is not above 95, but less than 95. Some of them will have 90 to 95, which is mild hypoxemia, not yet into respiratory failure, and there will be others who are requiring long-term oxygen, so they are having saturation of less than 90. So in these patients, when they are exposed to lower alveolar oxygen, what will happen? The PaO2 will fall drastically. So a person who is compensated at sea level, he'll decompensate and go to respiratory failure when traveling in air. So respiratory rate will go up. We'll try to hyperventilate. If the chest wall and lung disease does not allow increase in ventilation, what will happen? Carbon dioxide retention will occur. Work of breathing will increase. So these are the physiological changes that occur in patients who have got chronic respiratory diseases. So this change in respiratory mechanics and blood gas is one thing. The other thing that happens is that when pressure decreases in the aircraft, coming down to around 600 millimeters, so Boyle's law kicks in, and Boyle's law is that pressure and volume are inversely proportional. So when pressure goes down, the volume of closed spaces goes up. Closed spaces in body include gas in sinuses, in intestines, and non-communicating areas in lungs in patients who got respiratory. So these will expand. So there is a risk of volume trauma because of changes in volume consequent upon decline in the atmospheric pressure. So once there is worsening of hypoxemia, sympathetic overdrive starts, cardiac dysfunction starts. So patients of chronic respiratory disease, therefore, at a risk of increased work of breathing, worsening of their blood gases, increased symptoms, increased volume of air-containing spaces, and worsening of cardiac function and sympathetic stimulation. So therefore, patients with pre-existing chronic lung disease require a pre-flight assessment for their safety, as well as taking steps to prevent these complications. So that is the reason why this topic was taken up. And as pulmonologists taking care of these patients, we are required to give an opinion whether the patient requires any in-flight support or not. This in-flight support could be something as simple as oxygen, could be a non-invasive ventilation pulse. And then they have to be certified that they require a wheelchair access. So all these certifications are required to be submitted to the airline so that the air travel can be made safer and more comfortable for patients who have got chronic respiratory disease. So that is the starting introduction from me on the physics and the physiological changes which occur in the respiratory system. So over to Dr. Chandrakant for further panel discussion.
Thank you very much, sir. Thank you. Yeah, Miss highlighted well what are the changes of the oxygen at the ground level in the flight and how they pressurize the cabin and everything. Now we'll come to the panel discussion. We have the excellent panel today to discuss various aspects of the air travel in the lung patients. And a few of the initial my questions may be repeated for the person, but those persons who have joined late, they can also get benefit from these questions. My first question to Dr. Jainam. Dr. Jainam, what are the layers of the Earth atmosphere and how the chemical composition or the partial pressure or temperature changes as we go from one layer to each other layer and as we ascend, especially at the where the flight flies in which layer of the this thing Earth's atmosphere. Exactly what changes happens over there, Dr. Jainam?
Good evening, sir. First of all, I want to thank CCI and Krishna sir and Atri sir and all the team members that to give me such a wonderful opportunity to share the stage with the stalwarts of the pulmonary medicine. Referring to the question, what ask you, sir? What you asked, sir? In Earth atmosphere, there are that is composed of 5 layers. The innermost layer is troposphere, which is from that extend from the sea level to the 18 to 15 kilometers of the altitude. Then comes the stratosphere, then comes the mesosphere, then comes the thermosphere, and then the outermost layer, which is called as exosphere. The chemical composition of the troposphere is the same as what is at the sea level. It is almost the constant, and it is composed of the 21% oxygen, 78% of nitrogen, and 1% of the other gases. What happens when we ascend up? Then there is a partial pressure of oxygen decreases, and partial pressure of oxygen decreases due to decrease in the atmospheric pressure. So that give rise to hypobaric hypoxia. However, the percentage of oxygen in the atmospheric air remains the same.
Yes, Dr. Jainam, you have explained well the chemical composition, that is oxygen will be 21% only, but as the partial pressure of oxygen decreases, patient or any person can feel hypoxia. But there will be some changes in the cabin environment, as already Dr. Chhabra explained. But to revise it, I'll ask Dr. Narendra Kumar, what is the exact air cabin environment and at what altitude the air flight cruises and how they maintain the pressure. Can you tell the details regarding the cabin environment? Dr. Narendra Kumar. You are on mute, Dr. Narendra Kumar. Please unmute yourself. Yes.
First of all, I would like to thank Dr. Krishna sir and Dr. Atri sir for giving me this opportunity. And coming to the cabin environment, first of all, we need to understand what the flight cabin is. The aircraft, which the commercial aircrafts which we travel, they fly at a level above 36,000 feet from the sea level. At these heights, the temperature will be declined in a linear pattern, but the pressure decline will be in exponential form. So, in order to withstand these pressure changes, the aircrafts are built with a specialized pressure maintaining systems. What these aircrafts does is they have this cabin, the aircraft cabin in which we are seated. it consists of a pressurized system which takes the air from the outside, from the engine. It is cooled, it is compressed, and it is mixed with oxygen, and it will be circulated throughout the cabin in order to maintain the pressure and oxygen levels. What happens is, after every 2 to 3 minutes, around 50% of the air in this cabin is expelled from the aircraft through apparatus from the which is situated from the tail, and again 50% of the air is taken again from engines, and it is cooled, compressed, and it is mixed with the oxygen, so that this process will be continuous, so that the pressure in the cabin is maintained, which is around 8,000 feet, so that there won't be any changes for the lung physiology of
Yes, as you said rightly, although the flight cruises at the height of 36,000 or 40,000 feet, but they pressurize the cabin to simulate the height of 8,000 feet. They cannot make just like ground level due to technical reasons, and that's the reason. Although it's flying at 36,000 feet, the 8,000 feet simulated height gives us around 15% oxygen. Chabra says comment, please.
Yeah, so, just to add a bit of information, see, the aircraft is flying at 35,000, and before the flight takes off, they give the demonstration. The crew gives a demonstration. And one of the points which now we must realize why they say is that they say that when the pressure in the cabin will fall, the overhead oxygen mask will automatically fall down.
That is called cabin decompression, sir.
So that is because if by chance there is a failure of the system, then it will amount to that we are flying at around 35,000, which is incompatible. So we will require oxygen. That is why immediately the oxygen masks these fall down. Otherwise, everybody will die in the aircraft if there is a leakage. So that's a very important announcement. Normally, we ignore that what this crew is saying, but that has significance.
Yes, sir. In any uneventful incidents, if there is any leakage in the cabin, the sudden oxygen mask will come.
So that's
we might have seen in many movies also, sir.
There was some incident, sir. I think, sir, long time back. I think that incident is called some ghost fight event. That wall where the exhaust air goes, that there's a malfunctional, and suddenly pressure drops, and almost all the people in the flight died, and the aircraft was flying with all the dead bodies. That was the situation because of the loss of the pressure. That was unfortunate. Now coming to the next question to the Dr. Keerat Kaur Sibia. What are the common medical emergencies a person can face in the flight, and how common these are the emergencies? What are the statistics says?
Good evening to all viewers for today's webinar, and thank you for such a wonderful discussion, Dr. Chandrakant. And I want to thank Dr. Krishna for this wonderful idea of a webinar, this wonderful concept. And first of all, I'd like to ask the panelists present here, have you ever witnessed a medical emergency in air?
Many times.
Yes, many times.
Minor ones, never a cardiac arrest, but sometimes they ask, is there a doctor on board? Minor problems.
Minor problem. Okay. So generally, so if we say, suffice to say that the incidence is low. The incidence as per the BTS working committee, which was assigned the job of making guidelines for air travel, is that they worked up and they found out that 1 in 600 flights, or approximately 1 in 30,000 passengers in air, they had some medical emergency. Of these, they say about 12% were emergencies pertaining to the pulmonary health. Now, a number of medical emergencies can come up. I can say I witnessed one emergency, but that was on air. Patient waiting to board, had a cardiac arrest, had metabolic acidosis. Later turned out he had missed his regular dialysis. This patient was on dialysis and had skipped it. So we would rarely think of a renal emergency, but renal emergencies can be there. Cardiac emergencies, we all can understand that arrhythmias can take place. And in case of hypoxia, we would have, it would precipitate myocardial ischemia. We could think of having a cerebrovascular, we could accident, a stroke or a seizure, obstetric emergencies we can imagine. When it comes to pulmonary emergencies, there can be quite a spectrum. A simple dyspnea or a precipitation of breathlessness could be because of exacerbation of an underlying respiratory disease. It could be an exacerbation of obstructive airway disease like COPD, asthma, or it could be something acute like pulmonary embolism. Other diseases could also be there, like maybe person choked on something while eating on the aeroplane. I know it's not something we can scrutinize people for, but that's also an emergency, and that has to be catered for as well. Then there could be people who could be having OHS or OSA and who could go into CO2 narcosis. So a spectrum of emergencies can arise. And the fact that the numbers are low means, one, maybe such people are already declared unfit, but from the health perspective, and when someone is very sick, they are definitely going to have some physician locally who will tell them, no, you're not fit to fly. Even they may not be undergoing the procedures or the kind of protocolized determination of fitness to fly, but local physician, local chest physician may be advising them that they're not well enough. And maybe people also refrain from the fear of disease and also the fact that medical health insurance is very expensive. So low numbers, but still significant enough to warrant the BTS to be making guidelines since 2002 through 2011 to 2022, the latest guidelines which came out. So significant numbers worldwide.
Yes, that is actually, even if the number is less, but it can cause significant impact, as Chabra sir explained. Even one flight get diverted, that crew members, even that finances involved, even the co-passengers will face the problem, that all the bigger issues are involved. That's why it's important to evaluate the patient to prevent such manage aircraft emergencies. Now we have Dr. Apar Jindal. Just want to
And sir,
yes.
maybe not a direct emergency, but say one person flying with COVID means many, many more emergencies
Yes,
have been
yes,
had.
yes. And these are the problems. And Dr. Apar Jindal just wanted to ask regarding this pre-flight evaluation, and which portion we should evaluate for before air travel.
Thank you, Chandrakant. I think this is one of the most important things that we can discuss is which patient should be evaluated. And I think the most important patient that needs to be evaluated is somebody who has had an emergency in the flight. There cannot be anybody more important than that. Somebody who's had a past experience, definitely he needs to undergo a complete set of evaluation from whatever is possible from A to Z. Apart from this, I would say that anybody with a coexisting lung condition, that could be an infectious condition, that could be a non-infectious condition. Obviously, we are not going to let anybody with an active TB or an active viral infection or an active fungal infection travel in a closed environment like a flight. But yes, what we have to look upon is how much time has elapsed from their acute illness that they can fly. When we talk about the non-communicable illnesses, if we are looking at the airway diseases, a patient who's got an uncontrolled asthma, a patient who's got chronic COPD, or let's talk about the other diseases, a patient of ILD, somebody who's had a pleural pathology, somebody who's got a lung cancer, somebody who's had undergone a surgery, or somebody who's at a high risk for developing thromboembolism. I think this is a close subset of patients, and bear in mind, we are all referring to the BTS guidelines over here, but I'm not talking about the pediatric population. We are all adult physicians, so let's, I think, stick to that. But I think these are some of the important categories. These are the patients that we really need to look at whenever they're traveling. And most of us cater to this huge subset of this population. So I think it's part of the disease education that we need to start telling them that at any point of time, if you're flying, you need to have a consultation with us. You need to make sure that it is safe for you to fly. Always safer than sorry. So letting them fly and having an emergency or an exacerbation post-landing, it is better that they undergo an evaluation and the appropriate arrangements can be made on flight. So when you're talking about the pre-flight evaluation, what you would do, so always the hypoxia challenge test comes up. And unfortunately, there is no center in India which does a proper hypoxia challenge test. Then we talk about regression equations, that how can we, predict what would be the PO2, what would be the saturations of a patient when he goes to a certain altitudes. But these are again very difficult to do. It's more of a mathematician's job and a physicist's job than our job, doing a PFT. And many of our patients will not be able to do a proper PFT. Chhabra sir is here. He's the guru of PFT for the entire country, and he can vouch for that. How many of these patients who are actually chronically ill will be able to do a good PFT just for the sake of, getting to know whether they can fly or not. So we have to sort of rely mostly on our clinical judgment and some of the tools which we have available. Some basic tools, like what is the respiratory rate of the patient? When you're examining the patient, how hard is he breathing? What is the dyspnea scale that the patient has? And simple things like what is the saturation that the patient is maintaining on ground level? You can get an ABG done. Let's look at what the PO2 is at ground level for these patients. So as a dictum, now like the hypoxia challenge test that says that a patient is safe to travel if the PO2 is above, say, 50 millimeters of mercury, or the saturation at ground level is above 95% in room air. But how does this translate to normal patients? So I think we can use a double cutoff if the PO2 is nearly 100 or 90 and above, and if the saturation is around 95, that could be a fair amount of correlation between the two factors, and these could be the patients. This could be how you can assess these patients. Other than that, the standard tests that, whether the patient has a pulmonary hypertension on echo, whether the patient is able to walk or desaturating on a 6-minute walk test, our usual respiratory arsenal, I think a combined clinical and data-based evaluation can help us derive whether one of our chronic patient is fit to travel or not. So it's a complex situation, but I think it is more of a clinical judgment from the physicians. And, maybe Chhabra sir can add a little bit to that.
Yes, very well explained, Dr. Apar.
Dr. Jindal has clearly told us that it's not an easy task for a clinician to give evidence-based opinion on whether a person is fit to fly or not, considering the resources which are available. We were talking about hypoxic challenge test a little later, but that is more theory than a practical thing. See, the objective is to find out whether the patient is at a risk of going into a dangerous level of respiratory failure. So that is the reason why the patient has to have a pre-flight assessment. But like I mentioned in the beginning, there is no declaration required from the airlines that a patient has a respiratory disease. And very few patients actually volunteer this information to their physician that I am traveling and am I fit to travel or not. Only those who are already aware. So like Dr. Jindal made a very good point that when we talk to these patients and we anticipate that in future they may be traveling, so they should be sensitized at that point only that this is an important consideration, and whenever you fly, please do get a checkup. So those patients who are stable and having a saturation above 95, in them the risk of desaturating is minimal and they can safely fly. Those who are less than 92, clearly they would always require oxygen. So for them, we have to give a certificate. 92 to 95 depends on what is the anticipated risk. If they have got a previous history of exacerbations, previous episodes of hypercapnia, poor lung function, or in ILDs, DLC of less than 50%, or significant cardiac failure. So it's always better to err on the safer side and advise them to use in-flight oxygen rather than take a chance. So above 95 saturation, stable patient, I would say, okay, go ahead, no risk. 90 to 95, depending on patient's risk factors, better to advise that they should have a wheelchair access as well as in-flight oxygen. Because aircrafts are more than willing to provide, and they can even let you take your own point-of-care devices with you on that. So it's a clinical judgment coupled with a few basic measurements. Most important is the pulse oximetry.
Yes, sir, as you had said and Dr. Apar said, Basically, history, physical examination, and basic pulse oximetry, and if the patient is able to perform PFT, 6-minute walk test. These are the important things to examine before travel if the patient asks for the fitness for travel. Now, next question to Sir, you only, Professor Chhabra, sir. How to perform the hypoxia challenge test and how to interpret it?
So
Please
now,
explain us.
Hypoxia challenge test is described in literature. It's also described in guidelines, and there are also indications described. But I have never done this. The reason is that setting up a lab for this requires resources, and since we don't get a stream of patients that every day 2 or 3 patients are coming, or there's no specific referral center for fitness flying, so that is why this is not there. The only place where I've seen this test being done is defense laboratories. I am a consultant with DPAS. They do high altitude work, so there these tests are done routinely. So in the aircraft, the pressure is 8,000. So this can be equated to breathing 15% FiO2 at sea level. So that is the principle behind an HCT, that we give the patient 15% FiO2 to breathe for about 20 minutes and then see what is the fall in the PaO2. Now, how to give this 15%? Either we can have a cylinder which is filled up with 15% oxygen, but then, like I said, only in a center which is regularly doing this, only they will keep these cylinders. That is why routine labs will never do this. The other option is to use a simple 40% venturi and use nitrogen to flow through that. It will emplane room air and give you 15% FiO2. So that is the other way. So 20 minutes challenge. If the PO2 falls to less than 50, then this patient requires in-flight oxygen. If it remains above 50, then this is likely not to require. So that is how the test is interpreted. But again, reiterating, this is only theory. Nobody does it, and nobody is ever going to do it except DPAS centers. Dr. Jindal wants to add.
So the real challenge, even in the Western center. So I was at some of the institutes where this is routinely performed. Like some centers in the US, some centers in the UK do use this, especially for their sicker patients. The problem is that the hypoxia challenge test does not stop at this point of time. So if we find that the PO2 is falling to less than 50 millimeters of mercury, titration of oxygen, how much oxygen should be prescribed in flight, that is a separate challenge in its own. Because as you rightly said, the mixtures are not very readily available. And when we start converting into an oxygen supplementation test at 1 liters or 2 liters or 3 liters and constantly keep measuring the PO2s and the increase in the saturations, it's a very difficult thing to do. Because at that point of time, it is very difficult to control how much of FiO2 we are actually giving to the patient. So doing the test in itself is a nightmare, and then titrating how much oxygen to prescribe again goes very difficult.
That's why I said it's only theory, not a practical thing.
I think, sir, only this test we have
absolutely.
for the testing only. I think this only test we have. And I think in future, I think we should get some advanced lab, some advanced test to check
the rule
for
of
the
thumb on
fitness.
titration, patient who is already on LTOT, we simply add 2 liters extra for in-flight.
Correct. Sir, we have one related question from the audience. Dr. Surendra Reddy from Telangana has asked, is there any role of CPAT as we don't have hypoxia challenges available everywhere in India? Is there a role of CPAT, cardiopulmonary exercise testing? Chhabra, sir.
The purpose of CPAT is entirely different. The CPAT basically looks at respiratory and the cardiac fitness to perform a certain exercise. In the hypoxia challenge test, we are looking at the risk of developing hypoxemia. So the aspect of physiology which is assessed by the two tests is entirely different. So CPAT has no role in assessing suitability or fitness for flying.
Yes,
see, I think everything comes back to the same thing. When we're talking about a CPAT, you don't prescribe a CPAT to every patient that walks into your clinic. You reserve it for some of those chronic patients where you want a proper assessment of the cardiac limitation versus respiratory limitations versus how they're performing with their rehabilitation. So this becomes again the point comes back to counseling of the patient. This is already a chronic patient. The patient already has either a cardiac or a respiratory limitation with them. So this patient is already under assessment for whether or not he is fit for travel. So CPT at that point of time may really not add any value to it.
Like I said, the aspect of physiology that we have said, that there we are looking at the mechanism of dyspnea and the patient and the patient's fitting. It's the gas exchange issue.
Yes, sir. I think we'll move to next question. Most common patient we have the COPD patient. These are the commonly we get in our OP practice. Next question, Dr. Jainam, Navadiya. And is every COPD patient has a risk to travel in the flight, or how do you evaluate this patient for travel? And what are the risks involved in the COPD patient, please?
Yes. COPD patients having a certain risk factor during air travel. Like patients of COPD may feel hypoxia due to decrease in the oxygen level in the aircraft, number one. Then patient may have risk of barotrauma due to change in the cabin pressure during takeoff and the landing that may lead to pneumothorax. Then patient may have a cardiovascular risk factor like arrhythmia and ischemic chest pain and this thing due to severe hypoxemia in the aircraft. Then patient may have a risk of infection due to immunocompromised state in a COPD. Then patient may have a risk of thromboembolism if flight is for the prolonged duration. So COPD patients should be thoroughly assessed before they travel, air travel. So the patient who's we need to check his spirometry, his arterial blood gas analysis, his treatment status, everything before they travel to the aircraft. So if patient's SpO2 level, as sir told, that SpO2 level stays above 95 and patient's dyspnea scale is MMRC grade 1 or 2, then this patient doesn't require in-flight oxygenation and they can safely travel. But if patient SpO2 levels stays between 92 to 95 and then patients have hypoxia, after 6-minute walk test, patient's SpO2 levels falls below 84%, then this patient requires 2 liters of oxygen. Or in a theoretical terms, we can do a hypoxic challenge test when there is a risk of hypercapnia is there, because COPD patient have a risk of hypercapnia. Then patient who are COPD patient who are already on the LTOT, then that patients we need to increase the flow by 2 liters than what is patient is actually getting. And we need to readily, patients should have in the hand baggage, they have inhalers and the spacers and all the things. If patient may feel exacerbation during the flight, then they can take this. So in COPD patient, we need to take all these measures.
Yes, sir. Basically, mild COPD patient doesn't require any evaluation, but moderate to severe COPD patient, we should go in individual way. We have to check all these parameters, and in certain cases only we can do some advanced testing. Now, next question is asthma. Does asthma patient faces any problem on the flight, and how to manage any exacerbation that occurs on the flight? My next question is to Dr. Narendra Kumar.
So, generally, these commercial flights, these do not pose any problem for stable asthmatics. What happens is the cabin humidity will be very low in compared to the sea level humidity. This leads to bronchial mucosal water loss, which again leads to bronchospasm. But this hypobaric hypoxia does not pose any risk in stable asthmatics. But when coming to severe asthmatics, there might be a chance of in-flight hypoxia. And there was a retrospective study when we are talking about HCT itself. There was a retrospective study conducted in 2007. It was done on 37 patients, of which 21 patients were met with the criteria for O2 prescription. But when compared to the data, the positive patients, there was no any relation when compared to the sea level SpO2 or PaO2. The only finding they found out was the PEFR and FEV1 or FEV1 by FVC ratio was comparatively better in the patients with the HCT was negative. And the lung function was obstructive in patients whose oxygen requirement was met. And coming to the exacerbation part, usually these aircraft, the flights, every asthmatic patients are allowed to carry on their own bronchodilators. Or there will be an emergency kit is also available in the board, for whom there will be any chance we can ask the flight attendants and they will administer this bronchodilators, and it should be repeated till the bronchospasm is relieved. And when coming to pre-flight assessment in asthmatics, if the FEV1 is less than 30%, the patients are advised not to take the risk and let them have the proper medication, and we should ask them to come back again to visit the physician. And all other medications, including prednisolone and all those things, we should ask them to carry through the flight.
Yes, very well explained, Dr. Narendra. Now, next question to Dr. Keerat. We have commonly these patients with this bronchiectasis, both cystic fibrosis and non-cystic fibrosis. What problems this patient can get and how to manage it? What are the common problems and how to give fitness to them? Bronchiectasis patient. You are mute, Dr. Keerat.
Yes, sir. So cystic fibrosis or non-cystic fibrosis bronchiectasis. First of all, for any pulmonary disease, if someone is unfit on air to be going about their daily activities, there is an exacerbation. That itself is something which needs to be welcomed to. And a good amount of time recommended, say 3 weeks post that episode, is the time that we need to be given. So if a patient with cystic fibrosis who is at increased risk of exacerbations because of, say, the time of the year, the weather, or has had a recent month, he has had frequent exacerbations, then this is an alarm sign. And this alarm sign we need to take into consideration. A good history. Is the patient having some chronic infection which we are still not able to diagnose, or we think the patient needs further evaluation for some ongoing infection? All that needs to be ruled out as well. And when it comes to fitness to fly, what is seen in as per the BTS guidelines, they have recommended that HCT, that is the hypoxia challenge test, that had a sensitivity of 99% for predicting the oxygen requirement during air travel. And the cutoff for that was at an FiO2 of standard FiO2 0.15, that is during HCT. If saturation falls to less than 90%, then they predicted that requirement of oxygen will be there during flight. And on spirometry, for an FiO2 less than 50% of FEV1 less than 50% of predicted, they said the sensitivity was 96%. But the sensitivity was far greater with spirometry. An FEV1 of less than 50% predicted on spirometry had a sensitivity of 70%, and a saturation of less than 90% on HCT, hypoxia challenge test, had a sensitivity of only 20%, which means if we were to apply or subject most patients for a pre-flight evaluation, if they were to go through the much expensive and not so readily available and very technically advanced test, that is the hypoxia challenge test, it would miss out on a substantial number of cases who would eventually have oxygen requirement during their travel. So what the BTS actually advises is that one should go in for spirometry first. And if somebody has a low FEV1 of less than 50%, then they should be further subjected to hypoxia challenge test. And they found that the combined sensitivity of combining the tests went up to 80%. Now, how do we deal with these cases? cystic fibrosis bronchiectasis or non-cystic fibrosis bronchiectasis. One, definitely, patient should not be currently running an infection, should not be currently in an or recently have come out of an acute exacerbation. Then they have put special emphasis, the British Thoracic Society, on good hand hygiene. They have even bothered to mention that we should advise the patient on cleaning the armrests, the handrails, the trays in front of them, even the food trays. And when they go to the toilet, handles, everything, after they're handling, touching anything, they should not touch their face. This is the extent that they have advised on to avoid such patients getting an infection. Other than that, definitely they should be carrying the medications. The medications should be in the cabin baggage or the hand luggage, and they should be readily available. If they have an assistant, the assistant should be also aware of the management. Like we have an asthma management plan or COPD management plan that every patient should be carrying. A cystic fibrosis patient or a non-CF bronchiectasis patient should also be carrying his plan. It can be on paper or on his cell phone, his or her cell phone. And PEEP devices, positive expiratory, positive pressure devices, they should be available. And if the patient is carrying such device, carrying a nebulizer, the airline has to be told that he is going to be carrying this particular device, and the person needs approval from the airline, and that needs to be well planned.
That's well elaborated, Dr. Keerat. And with this, I want to tell one thing. With this excellent talk by Chhabra sir and all the panelists, they are giving excellent explanation for each and every aspect of air travel. We are having almost 985 logins, as informed by our founder, trustee Dr. N.H. Krishna sir. Almost 985 people are there who are watching us live now. So let's continue our program. My next question is to the sleep medicine and lung transplant expert, Dr. Apar Jindal. How to manage this OSA, OHS, and obese patient on the flight, what problems they can get, and how to manage all the CPAP related issues, and how to address it. Dr. Apar Jindal.
Chandrakant, I'd like to bring in a lighter note into this answer. So we all know that OHS and OSA patients, they can go in for CO2 narcosis and all those things can happen. But nowadays, most of these patients have become, smart enough to carry their CPAP devices on board if they are going for, say, an international flight where they would be sleeping for a couple of hours. If it's a small flight, 1 hour or 2 hour or 3 hour at most, which is the standard flying time in India, I don't think it is going to make much of a difference to them. But yes, if these patients also have other comorbidities, if we are talking about that small subset of obesity, hypoventilation syndrome, patients who are hypoxic, who are very breathless, even at ground level, then of course they go through the same grind, they go through a pre-flight evaluation. And if found to be positively requiring oxygen, the recommendation would appropriately go through. Few things they have to bear in mind is that we do not have a proper power circuit in most of the flights. So the devices, if at all they need to use them, have to be battery operated, and they should be able to use that. Now, international flights, most of the standard companies, to name a few, Emirates or Etihad or even the American Airlines, Air Canada, Air New Zealand, all of these flights also will provide you with a CPAP device if it has been recommended in a medical form by a doctor, by the treating physician. So if at all you do not have a battery powered device, either arrange it or make sure that you have a certificate well advanced placed with the airline so that the device can be arranged for you on board. That is a possibility. Apart from this, I think the major issue will not be with them. The major issue will be for the people sitting next to them, because these people are going to snore away to glory unless they're using their CPAP. So I don't know how the other people are going to sleep over that. But yes, one more problem that I can see, and again taking it on a lighter note, is that I don't know if you guys have gone through this particular bit of information, but Air New Zealand has become the world's first airlines to actually weigh the passenger along with the baggage. And according to the category of the ticket that you're purchasing and your weight, if they have slabs, and if you are higher than that, then you have to pay extra. And if you are above 200 pounds or maybe 100 kilos, you have to buy 2 seats. So that may be another added issue that these people may face. That's apart from the medical issues.
Uh, that's excellent answer, and especially related to these issues also, especially pressures related issue. Can you comment on that, BiPAP and CPAP related pressures? Because on heights, partial pressure will be less. How to adjust it?
So, see, I think when it comes to the pressure, more than we also have to take into account the acceptability of the patient. Most of the patients have become used to a certain amount of pressure, the force of the air, the jet hitting their face or hitting their nose whenever they're using this. So unless there is a huge discrepancy, somebody who's on very high pressures or somebody who's got an underlying lung problem, say a bullous lung disease or emphysematous bullae, I wouldn't play around too much. It is recommended that you reduce the pressure that can be provided to them. But yes, keeping the same pressures unless there is an underlying lung disease might be, it might be okay with the patient because they're used to feeling that much. I mean, see, again, there is not enough data. I mean, I don't know if there is enough data on this, but yes, that this could be just a practical tool.
The pressures that we give to these people, these are atmospheric pressure plus that. So whatever the atmospheric pressure, so pressure has to be the usual one which they are taking at sea level. This 10 centimeter or 15 centimeter, this atmosphere plus that pressure. So that plus will remain the same whether they are in flight or on sea level. So
yes, sir.
they are accustomed to that pressure.
Now, next subset of patient, we get many pneumothorax patient or those patients who are predisposed for the pneumothorax. How to manage this patient? My question to Professor SK Chhabra, sir.
There are a lot of conditions, like I explained in the beginning, when the atmospheric pressure falls, then closed spaces will increase the volume. So patients who have got cystic lung disease, especially LAM, or even smokers with small blebs which are not discovered earlier, or patients who have got one episode of pneumothorax. So there, the risk of pneumothorax definitely is higher when they are lying. Now, apart from warning these patients, there is little that we can do. We cannot declare that they are unfit to travel if they are otherwise stable and maintaining a normal saturation. Those who have had a pneumothorax and required an intercostal tube, for them, we would like that they become stable. So, an infection is controlled, exacerbation is controlled, lung must be expanded. And what the guidelines say is that at least 1 week after the lung has fully expanded and the tube is out, only then they should be certified that they can travel. Again, they should have attained a normal oxygen saturation. And if there was any effective exacerbation, that should have been controlled, and at least 4 to 6 weeks after that. So these are the precautions that we need to take in patients who have got pneumothorax.
Yes, sir. Now, I think you have explained in details regarding pneumothorax. We'll go further. We'll go to further questions. Now we have the majority of patients with some restrictive lung diseases. I will combine the question into one question. We have the ILD patient, some patient with the kyphoscoliosis, or some patient with the muscular disorder. All these patients with the restrictive category. What are the issues with this patient and how to give the fitness for travel? This question is to Dr. Jainam, Navadiya.
So first of all, we are in the restrictive lung disease, they are having a compromised lung. So we need to address and we thoroughly assess that patients, that ILD patient, the restrictive lung disease patients. So first of all, we are talking about the ILD. In ILD, what we need to see is about the SpO2 levels. If patient's SpO2 level stays above 95%, and after 6-minute walk test also, if patient saturation level stays above 95%, then this patient are safe to travel and there no in-flight oxygen is required. But if patient have compromised lung function, like patient having a TLCO less than or equal to predicted 50% of predicted, or patient is having a PaO2 of less than 9.2 kilopascal, then this patient may require a 2 liter of oxygen or may require a hypoxia challenge test. Then talking about the other restrictive lung disease like chest wall disorder or neuromuscular disorder, this patient we need to check the spirometry and we need to see that if patient's FVC is less than 1 liter, then this patient may require hypoxia challenge test according to the BTS 2022 guidelines. And patients, we need to check his or her ABG to see there is a respiratory failure or not. Then majority of patient may require NIV. So we need to grant the permission from, or we need to readily available NIV for these patients. And we suggest this patient to travel in the daytime. This is all we need to think about this restrictive lung disease patients.
Yes, a good answer, Dr. Jainam. And in fact, even for the sleep apnea patient, daytime travel is preferred, and as well as for this neuromuscular patient, because nighttime they may retain the CO2. And now coming to next question, we get commonly patients with the hyperventilation, anxiety, some dysfunctional breathing, vocal cord dysfunction. How to address this patient? My next question is to Dr. Narendra Kumar.
So coming to these hyperventilation and dysfunctional breathing patients, and some panic attack disorders, and some patients with claustrophobia. These are usually first-time travelers. Generally, we see these type of things in first-time travelers. For these patients, we should have a pre-flight assessment, and we should advise them to have a specialist evaluation and treated accordingly. And during the in-flight, if there are any chances of breathlessness, which does not fall in any other category, better to give them oxygen and start medical assistance as soon as possible. And rebreathing techniques, these help a lot during these panic attacks. And pre-flight medications like anxiolytics should be given to these patients, so that there won't be any panic attacks or uneventful things during the flight.
Yes, as you said correctly. Actually, last month only, when I was traveling with the flight, I got any doctor on the board. One person was there with underlying some depression, anxiety. Actually, he was feeling breathless. Cabin crew was where they were very anxious. I went and saw. I asked him any previous history. With the history and examination, everything, his saturation was normal. And in fact, the cabin crew wanted to give some inhaler. But I gone through his previous medical record. He had some previous records. He has anxiety. Then I counseled the patient, and with the counseling, he calmed down. So that is the benefit of asking the history and basic examination. And now coming to the next important question. Now, many patients, they are traveling from different cities, especially for the procedure. For example, some CT guided biopsies. Nowadays, people are doing e-bus. If one city is not able, they are going to different city for e-bus. They are undergoing multiple procedures like thoracocentesis and thoracic surgeries. So how to when to give the clearance after, because after finishing surgery they has to go back to their own city. After how many days we can give the clearance? This is my question to Dr. Keerat Kaur.
So, sir, this is a very valid question, and as pulmonologists, we should all be aware that whenever we are taking such a decision as an intervention pulmonologist, or when we are taking a decision for a patient who has undergone a thoracic surgery, the decision has to be made taking the thoracic surgeon on board. Because the thoracic surgeon will tell us if there are any lacunae that we might be missing, if there is any risk for airspace issues. In the sense, there could be he could be expecting that he knows the status of the sutures, he knows what he's seen inside when he was doing the back surgery or an open surgery. The guidelines as per the BTS are that 1 week after the drains are out, 1 month, 4 weeks after the thoracic surgery, and 4 weeks after the drains are out, the patient is generally considered fit to fly. And in case of any intervention such as TBNA, DBLV, or EBUS, if there is no pneumothorax post-procedure on the chest X-ray, then after 1 week, it is considered safe for patient to fly. And if there is a pneumothorax, then 1 week after we have affirmed that the pneumothorax has resolved and the chest X-ray is clear, 1 week from that, the patient is considered to be fit to fly.
So as you said, grossly for any pneumothorax patient, we should wait for at least 1 week till after resolution of the pneumothorax. And for procedure like TBLB and other things, if there is a no pneumothorax post-procedure, I think patient can fit for fly.
May I also add that post-fluorodesis, the recurrence is of any pleural pathology as in during air travel is supposed to be very low, but it is 4 times more VATS surgery of any kind. So it would be imperative to actually wait at least 4 weeks after any major surgery.
Yes. My next question to Dr. Apar Jindal. We have the many pulmonary hypertension patient, but there remain always confusion. Which category of patient can fly, which category of patient can't fly, which category of patient can fly with supplemental oxygen. Please explain us, Dr. Apar Jindal.
See, I think, Chandrakant, this is the ticking time bomb group because most of these pulmonary hypertension patients, when we are talking about pulmonary hypertension, I think I'll take group 1 pulmonary hypertension into account over here because all the other groups, if you're talking about the respiratory pulmonary hypertension, so we've already discussed most of the diseases. We've discussed the ILD, we've discussed the COPD over here. So if you're talking about isolated pulmonary hypertension, it's very clear that anybody who's falling into, say, NYHA classification of 3 or 4, they definitely will be very symptomatic. These are the patients who will be at risk when they fly, so they should be offered in-flight oxygen. Coming to group 1 and 2, or coming to group 3 or 4, who also have a comorbidity of having a right heart dysfunction, or these are the patients who come to this from an Eisenmenger, group 2 who have gone into severe pulmonary hypertension. These are the patients where it will be a dilemma. Giving them oxygen and giving them how much oxygen. Most of these patients are doing fine. They get used to low saturations over a period of time and they use oxygen either not at all or SOS even at ground level. But as we have discussed the high altitude physiologies, they will undergo stress. And here the stress is not only respiratory, it is also a pulmonary, it's actually a cardiopulmonary stress that they undergo. So not only will they go for hypoxia, they will be at a risk of developing arrhythmias also because of this sudden development of hypoxia. So this is the group that has to be very carefully assessed. The dictum that I use, since again the guidelines are not very, very clear, they just say that these patients should be offered oxygen. But how much oxygen? We don't have a hypoxia challenge test available with us. So what I practically use is any patient who has a pulmonary hypertension, say my arbitrary cutoff over here is a 45 systolic pressure. So if the PA systolic pressure, whatever we can estimate on the echo, if the RBSP is above 45, I will prescribe them 2 liters of oxygen irrespective of whatever the condition be. As the pressure goes on increasing, or anybody who is using oxygen, even SOS basis on on the ground level, I would just double it up. If they're using 1 liter, they need to use 2 liters in flight. If they're using 2 liters, they need to use 4 liters. And that is typically where the ceiling limit comes in our country, because most of the airlines will not provide oxygen above 4 liters. If you have to travel, if you have to take oxygen beyond that, then you have to have your POC device coupled with the oxygen which is given in flight. But you cannot carry a cylinder in flight. It is just not allowed. You can have your portable concentrator, and the flight can give you 4 liters of oxygen. Yes, again, few international flights do provide up to 6 liters of oxygen, but that is again the ceiling limit. Beyond that, you have to use an air ambulance service, which is like hugely expensive. So I think pulmonary hypertension is the tricky group that you have to assess. Very careful assessment as to what the condition is. Very careful assessment as to what the cardiac issues along with the pulmonary hypertension is, goes a long way into this, keeping these patients safe, especially when they travel. These are the ones who will look very normal to you. They will come walking into your OPD, unlike your sick patients, unlike your group 3 PH patients. But these are the ones who will actually fall ill if they fly without support.
Yes, and definitely. And there is no any emergency treatment that we can give in the flight. Just like asthma COPD patient, we can give some inhaler, but for PH patient, we can't do anything except oxygen. Now, next important question to Professor SK Chhabra, sir. Many patients during traveling, there is whether there is a risk of DVT or pulmonary embolism to this patient. And if already there is existing DVT or pulmonary embolism, What is your take on that, sir? Whether they can travel or when they can travel? Any precautions are required to prevent it?
See, as such, any prolonged immobility, that is a risk factor for occurrence of DVT, and some of these patients will have P. So that is a common risk factor for DVT and P of under any situation, especially with long flights. And within the country, see, flights are 2-3 hours or less than that. May not be able for international flights for long hours, and they are prolonged period of immobility. So what these patients, and if they have an underlying cardiac disease or chronic respiratory disease, chronic respiratory failure, and especially if there's an underlying malignancy, then the risk of occurrence of DVT greatly increases. So these patients have to be counseled that apart from optimizing their underlying condition, cardiac or respiratory, which we have discussed, including use of oxygen if required, prolonged immobility has to be avoided. And when on long flights, they should move around in the aircraft with oxygen if required. So they are always advised to have aisle seats so that they can move more easily. So movement is very important. Then passive limb exercises that they can do. Regarding those who have already had a DVT or on treatment, once they are on long-term treatment and they are taking their anticoagulants, then along with these preventive steps, they would be safe. But they should be on treatment. The risk of DVT is definitely there because of prolonged flights.
Yes, sir.
Chandrakant, I think one blanket rule that we should counsel all these patients, irrespective of any of the diseases, especially if they're taking international flights, is that no alcohol, stay away from coffee as much as you can, water intake has to be maintained, and keep walking around the flights. I think these 4 points will help more than anything else that we can do in the flight for them.
Yes, basically, crux is I think they should move.
Point one is not doable, I would say, for most patients. 2, 3, 4 are okay.
Sir, it is our duty to advise.
I know. Long flight, especially international flights.
Yes, sir. We'll move to next question. Already we have covered all these non-communicable diseases. Now coming to the malignant disease related part, we have many lung cancer patients. They move here and there for treatment or some other different reason. Next question, Dr. Jainam. We have the lung cancer patient or some other mesothelioma something. Can they travel safely in the flight?
This lung cancer and mesothelioma patient, we need to assess this air travel of this patient depends on the various factors like treatment status, what is the performance status of the patient, and what is the stage of the disease, and patient is require in-flight oxygenation or not. So this thing decided this patient can safely travel air travel or not. Patient who are receiving chemotherapy and having a severe side effect of this like nausea, vomiting, and patient who are receiving chemotherapy are having an increased risk of infection, then this patient should avoid air travel. Otherwise, this solely depends on the which stage of disease patient comes to us and what oxygen requirement that patient require. That all we need to advise.
Yes, definitely. Miss lung cancer patient with some chemotherapy, with some neutropenia, they are at the risk of infection. So we should carefully evaluate this patient and we should give the fitness to fly. And now coming to some little pediatric part, Dr. Narendra Kumar, some people ask for infants. How do you give the fitness for the infants, or when the infant can fly as per here this age of gestation? Please tell us. Please unmute yourself first.
Coming to the infants, for the infants born at term, that is more than 37 weeks of gestation, it is better to wait for 1 more week to see any health conditions before boarding the first flight. And for the infants who are premature, that is who are born before 37 weeks of gestation, if there are any signs of tachypnea or any RD, irrespective of the previous history of respiratory diseases or any infections, it is better to start them on oxygen. which is at least 1 to 2 liters during the flight. And for the infants more than 1 year of age and with the history of chronic respiratory distress, HCT is advised. Basing on HCT, if the infant has a SpO2 of less than 85%, in-flight oxygen should be recommended for these infants. And for another category, if the infants who are on oxygen dependent at the sea level, that is long-term oxygen therapy or home oxygen, for any reason, any kind of reason, simply they are advised to double their oxygen requirements during these flight journeys.
Yes, basically with the advice of the neonatologist and as per the BTS guidelines, we should follow this for the neonates. Now, coming to another aspects of children, commonly they suffer from the otitis media, sinusitis, or some upper airway infection. And at flight, there will be some changes in the pressure, especially some barotrauma risk. My next question, Dr. Keerat Sibia, how to whether this patient child can travel in the flight having with otitis media and sinusitis. Dr. Keerat.
Anyone who's traveling is going to be at risk of barotrauma. It has been documented and the BTS guidelines that otalgia because of difficulty in or disequilibrium in the middle and the external ear, pressure disequilibrium in the between the middle and the external ear, causing pain in the ear, and it is known to have. It has been documented to cause tympanic membrane changes in about 10% adults and 22% of children. This can lead to tympanic membrane perforation, but that is very, very rare. We, however, know that sinusitis and otitis media is an uncomfortable condition for anyone, not just kids, but for adults as well. To have a heavy head and malaise, it's an uncomfortable condition to be in. So if children who are anyway cranky when they're traveling, on top of it, they have sinusitis and they have
I think there are some network issues with Dr. Keerat's side. As he said, these patients with the children with the otitis media and sinusitis, if they're having some nose blockage or something, there will be pressure changes and they may feel discomfort while ascent and descent. And that's why these children should be supplemented with some decongestants, nasal sprays or drops before and during travel. And this can help to comfort them. Now, next question is to Dr. Apar Jindal, because we are having many COVID patients last 2 years, and nowadays cases are, but still, how to recommend them when to travel? COVID patient or some flu patient with viral infection, how to guide them when to travel?
Again, Chandrakant, this is again an area where we have to use our clinical judgment because the guidelines are not very, very assertive on this. Let's keep two different things over here. Let's talk about tuberculosis. We are pulmonary physicians. We cannot not talk about tuberculosis. And it's a no-brainer. Any smear positive case should not be allowed to travel, at least for up to 2 to 3 weeks of therapy, if it's a simple case. Smear negative cases, yes, there are further challenge. Again, at least 2 to 3 weeks of therapy. When we come to viral diseases, especially if there are outbreaks, if things like COVID, we've all gone through that. Flu outbreaks have been there. I think general hygiene guidelines, wearing of a mask, the regular hand hygiene, these things will help. But if a patient is symptomatic, definitely it's a no-no that the patient should not be allowed to travel. How long after being symptomatic the patient should not be allowed to travel? I think that would be disease specific. We would need to know the microbiology of the disease as to what would be the viral shedding time of that particular disease. So basically, like if you look at COVID, it started as 3 weeks of non-travel, then came down to 2 weeks of non-travel, then came down to 7 days of non-travel. So I think the more that we understand what each viral disease physiology would be or pathophysiology would be, that would help us to ascertain and certify whether the patient is fit to travel after a certain point of time or not. I think the only concrete point that the guidelines have made is that if anybody develops a proper pneumonia and he has had fall in the saturation of less than 94, then definitely for at least a week's period, air travel should be postponed in these patients. I think this is again going to be an area where you need to use a clinical judgment. The patient has become asymptomatic, the patient is afebrile. If it was an illness associated with a rash, all the rashes have disappeared, or at least the rashes are crusted and are not infected anymore. The safety here is not only for the patient, but also for the crew and the other passengers that we have to keep into account. So infections need to be curtailed and the patient need to be safe.
Yes, definitely. For every infectious disease, we should see the infectivity period, and as well as the patient should be fit in relation to the symptoms and as the safety of the fellow passengers. I think Dr. Chabra sir wanted to add some comment.
The problem here is that only for COVID and because of the pandemic, the regulations were made that a declaration is required. Dr. Jindal mentioned tuberculosis, and fair enough, a person is going to spread, so why allow him to travel? Point is declaration. Patient doesn't declare that he is on treatment, buys a ticket and travels. So that regulation is not there. So it's more a deficiency of regulatory requirement rather than patients. Patient will not go to his physician and ask whether I can travel or not. He simply books and travels. So there's no regulation apart from COVID. And that is a lacuna in our system. And I think as our public health awareness grows, maybe these statements would be required. Like we discussed earlier, chronic respiratory disease, no declaration is required whether you have this or not. So with growing awareness of health problems with air travel and need to protect the patient as well as others, I think these will have to come in like these have come in for COVID. So COVID, everything very well defined how we travel in COVID times.
I think one awareness that has definitely spread is the use of mask. Now, if you see, so many instances I've seen in the flights, any patient, any person, I shouldn't say a patient, any passenger, even if he develops a slightest of the cough, that could be for any reason, the adjoining passengers will start requesting them to wear a mask. Or, some people may even request the crew to tell the person to wear a mask. So I think that itself has a lot of repercussions that might, safeguard many other people.
Again, it's regulatory. Now, see, now masks are not mandated, so people don't wear masks.
But I think some patients, sir, they are getting aware. They are thinking from themselves also.
Yeah,
in terms of that disease should not become severe in the flight, and sometimes they think for the fellow passengers also, they should also get the disease. Now, coming to the tuberculosis, sir, what is your take on how they can travel? Tuberculosis patient.
Well, already Dr. Jindal has answered that question. So clearly, it's more to save others first. So patients should have converted. So, and again, it depends on what is the extent of pulmonary involvement. If it's an extensive tuberculosis and the patient has a saturation fall also, then clearly falls into the management of chronic respiratory disease and air travel. So these patients are well advised not to travel till they have recovered sufficient stability and have come out of that respiratory failure phase. The cavities have closed. Otherwise, all the complications that we find in chronic lung condition, they can occur theoretically in these patients also. So clearly, they should be negative. So generally, I tell my patient that in intensive phase, avoid as far as possible, except in emergency. And certainly, no travel permitted if they are sputum positive.
At least for 2 months,
at least
they should
and they should have clinically stabilized, maintaining a normal saturation.
Yes, sir. And in fact, sometimes pleural effusion also can cause some breathing difficulty. This patient can get difficulty in the flight, or some even previous some pneumothorax history with the tuberculosis. They also can get the problem. I think this patient should not travel in the flight.
The theoretical part is that any patient who has a limited lung reserve, when he's exposed to a hypoxic environment, is bound to go towards respiratory failure.
And now my next question is to Dr. Jainam. We get the many patients on oxygen. They want to go for treatment for different cities. How to recommend them when they can travel, how much oxygen they can use in the flight. The patient already on the long-term oxygen therapy.
As we all see that many of our patients, our COPD and ILD patients and pulmonary hypertension patients are already on the long-term oxygen therapy. So this patient, when they air travel, we need to increase the oxygen flow by 2 liter more than what is actually patient is receiving. So that we can do. And another thing is that in the flight, already we have discussed that they can provide us the maximum of oxygen is up to 4 liter. So if oxygen requirement is more than 4 liters, then in a commercial flight we can't. We should avoid. We ask the patient to avoid the flight.
Yes, as you rightly said, any patient on LTV, we have to increase by 2 liter. But if the requirement is more than 4 liter, that person can't fly it in the commercial flight. We need to book
Yes.
an air ambulance
Ambulance.
sort of thing. Now, coming to the other question, Dr. Narendra, what are the absolute contraindication of air travel? What are those patients that should not travel with the commercial flight?
Sir, as earlier discussed, any active tuberculosis patient and we have missed like drug-resistant TB cases and closed pneumothorax and a pneumothorax with persistent air leaks. These patients should not be allowed. And patients with massive hemoptysis, with recurrent massive hemoptysis episodes, and the patients who are on long-term oxygen therapy, as previously discussed, who require more than 4 liters of oxygen at the sea level. And for these patients, there is no point of giving any further oxygen in commercial aircraft.
Yes. Mm-hmm.
And patients with unstable arrhythmias and anginas, recent history of PTCAs.
Yes. Now we are coming to and the last few questions now. Now, most important practical question to Dr. Keerat Kaur. We have discussed HCT, we have discussed many things, but can you tell us and our audience the simpler and practical test or practical methods or assessment, how to give the fitness with the simpler measures, fitness to fly to any chronic respiratory disease patient?
Yes, sir. That's a very important question indeed. So we first of all, I'd like to refer to what Dr. Chhabra was saying, that yes, people will not come to a specialist unless they're very aware that they need to plan their own medical health requirements. For that, they might come. But in my experience, we are having a lot of patients who come for visa clearance. In my center, we have about 400 to 500 visa applicants every day for medical health. And I get the consultation for patients who have if anything flags up on their chest x-ray, who have history of any respiratory disease. And the different countries, they have health requirements. They will ask for certain tests. They will make sure that the sputum is negative, and they will not just go in for a gene expert or a negative RT-PCR or AFB smear staining. They will ask for a culture only. And this is what they are asking for is from a resident view, but it is also ensuring that people with active diseases are not flying. And they also ask for PFTs, and they will not have fitness if the FEV1 is less than 30%. So they have their own criteria, and it is different for different countries. Now, coming from how we assess such patients, when we also have to advise patients on air travel. First of all, is the history, any recent exacerbation, the severity of ongoing disease. We are saying that if the saturation, and in our discussion, we are talking, BTS is saying if saturation is more than 95% on room air, then this patient does not need oxygen. We are saying this patient is fine. But think of a case of asthma. Now think of a case of severe asthma. We do not classify someone as severe asthma based on their saturation. We classify based on their requirement of medication to control their symptoms. So somebody who could be really sick could still have a saturation which might be acceptable on room air. So this is where I feel is a major lacuna in our guidelines, which are still evolving. They are themselves admitting that these are evolving guidelines. So first of all, saturation. If it is more than 95%, as per BTS, the person does not require oxygen during flight. Next is spirometry. Next is 6-minute walk test. If on a walk test, a patient with obstructive airway disease is maintaining saturation more than 85%, they are saying this person does not require oxygen. But for a patient with restrictive lung disease, if on a 6-minute walk test, there is a dip in oxygen saturation, less than 95%, there's a higher threshold for restrictive lung diseases. This person is likely to require oxygen during air travel. Now, this is what the BTS is saying. Now, how do we go further? We do not have and they will recommend a hypoxia challenge test. We don't have it in our center. We will do a spirometry and we will try to ascertain what is the FEV1 like. We will try to see, is the patient breathless when the patient is walking into our OPD? If the patient is breathless, walking into our OPD, and I also want to point out here, when the highest or the most advanced test, hypoxia challenge test, Dr. Chhabra, I would like your inputs on this, sir. The test is done when the patient is in resting state. Patient is sitting and breathing for 20 minutes. Now, patient has to go on a longer flight. Patient will get up, go to the toilet. We are telling the patient that you should walk about, you should be a little more mobile also to prevent DBT. Are we really taking that into account? We are not. Actually, from this point of view, I feel that having a cardiopulmonary exercise testing makes sense. And I would like Dr. Jindal's opinion on this as well. That don't you think that CPET is actually giving us the cardiac reserve and the pulmonary reserve? That tells us that if a person exerts, how the person will be faring. And when someone is traveling, there is going to be some extra exertion. The patient is going to be exerting. So that increases the risk. And another thing I feel is iOS. We are not talking about iOS. There are cases where, BTS is saying less than 6 years, they cannot do spirometry. You just do HCT. We don't have HCT. What do? We do iOS. We get some idea, impulse oscillometry. We use all that we have at our disposal to see how a person is doing in totality. And then we make a call on whether we feel the person is fit to travel or no. I
Like
would really
Chhabra sir's comment on this
When,
related to
Yes.
iOS.
Firstly, let's see what is the problem. I have discussed the physiology. We are talking about in-flight problem. We're not talking of dyspnea in a patient, right? So dyspnea management is an entirely different thing. Here, the specific issue is the change in pressures and the risk of hypoxia. So that is the special consideration in flight. So here, an exercise challenge test will not really add to any information. That is why it is not included in any of the guidelines of the BTS. Now, a lot of discussion around SCT, and 1,000 people are listening to it, and they might feel disappointed they don't have access to this, and we have referred to HCT so much. Again, I'll reiterate, this is only theory, and if you don't have HCT, let us not bother. We can still certify the patients, a simple history and examination. If a patient who has got an NOHA class of 3 or 4 cardiac or a dyspnea of MRC grade 3 and 4, patients who have got severe restrictive disease, diffusion impairment, FEV1 less than 50%, risk of hypercapnia, these are the patients who are more likely to desaturate, or those who have desaturation on 6-minute walk test, and their room air saturation is 92 to 95. So these patients are better advised in-flight oxygen for their own safety. Only when they are stable and above 95, one can take a stance that in-flight oxygen is not required. Less than 92, definitely oxygen is required. So in-flight, the only issue is whether they require in-flight oxygen or not. So that is what, as pulmonologists, we have to certify. And now, I don't know how iOS come. That's an assessment of lung mechanics, not a predisposition to hypoxemia. So that is an entirely different aspect. So I don't think a complete assessment of lung mechanics is the issue. It's the risk of respiratory failure which is the issue in air travel.
Sir, one more question to you. Sir, this airlines, they do sometimes a 50 minutes walk test. And if the patient is able to walk 50 meter without any distress, that patient has to have, they consider to have good cardiorespiratory reserve. What is your take on that, sir?
Exactly. So that would be MRC grade 2, 1 or 2. So that is okay. That's what I said. MRC grade 3 or 4 or NOHA class 3, 4. These are the patients who would require assessment.
Yes.
50-meter walk is a screening tool which can be easily done in any kind of health setting, primary care or secondary care. And if patient can walk 50 meters without getting breathless, as per airline regulations, he is fit to travel.
Yes, 50-meter or 10 to 12
That is
stairs.
a test which is recognized and approved by international regulatory authorities.
Yes, Dr. Apar want to make some comment.
Keerat, the issue over here is the indication for doing investigations is not that you have the equipment to do the investigation. If you have an iOS, if you have a spirometry available, it is not necessary to use all of that at your disposal for a pre-flight assessment. We're talking about pre-flight assessment here. We are not talking about the respiratory condition management. Doing a CPAP, as sir has already mentioned, doing a CPAP or using the iOS, this will help you manage the patient better. It will help you know what is happening with the patient better. But nowhere, you rightly said that the spirometry in those trials was shown to be more sensitive as compared to the HCT. But nowhere has a cutoff been given that according to spirometry values, what would be your recommendation for oxygen supplementation in the flight? There is no table like in COPD as to at what FEV1 cutoffs, how much oxygen you should give, or whether or not to give oxygen to the patient depending upon the FEV1s. So the issue at hand is whether or not this patient should require additional care in the flight. CPAP in that way adds nothing more to it. If a patient is desaturating on exertion, you have to be more careful with this patient. Your recommendations there would be either a wheelchair or a stretcher, up to the stairs or up to the ramp, or a wheelchair up to the seat, whether or not the patient has to be assisted in the flight. I'm sure all of us have gone through the medical forms that the airlines have created, and nowhere they ask for all these details. The issues that we need to answer in these cases are these: whether or not the patient can travel alone, whether or not the patient has a disease that is going to be inconvenience to the other passengers, whether or not there is a mental issue that can be addressed, whether or not there is any comorbidity along with the condition that the patient is suffering from which can create complications, whether or not the patient can travel unassisted, whether or not the patient can use the bathroom facilities unassisted or not. So there your answer comes in. If the patient is desaturating on exertion, even on walking 15 steps or 20 steps, then yes, the patient has to be assisted, more oxygen has to be given, or the patient has to be deterred from taking longer flights. The patient can take only shorter flights where the bathroom visit can be avoided. Lastly, it will come to whether wheelchair assistance is required or a stretcher assistance is required, and till what point this is required. So if I can go into the oxygen logistics over here, and I think this is one of the very important things that the audience can understand. There are various levels of providing oxygen in flight in most of the domestic as well as international flights. You start with simple oxygen supplementation, as we've all discussed, which goes up to 4 liters. Then you can add your POC, which can go up to 6 liters, because the POCs, these are giving pulsed oxygen, and the maximum you go is 1 to 1.5 or at the most 2 liters with some of the devices. Beyond that, how does a patient travel? So it's not necessary that every patient who's requiring oxygen beyond this has to travel in an air ambulance. There is something called as a commercial medically assisted travel or transfer of patients as well. What they do is they will occupy 6 seats. They will occupy 2 rows, which will be curtained off in a flight, and a stretcher would be placed over there. You have to get special permission from the aircraft for doing this, and a medical team has to be present over there. So there are specialized air transfer teams available which do this. And with this enough amount of oxygen, whatever the patient may need, provided it is less than 10 liters per minute. So up to 10 liters is the cap that they allow in that. Less than that can be provided, and the patient can be brought. A doctor who is a certified emergency physician or a certified transfer physician has to be present. A technician who is well versed with respiratory equipment has to be present over there, and a nurse has to be present. So this sort of transfer is also possible, and it is possible in most of the airlines. Indigo at many times is one of the airlines which has not supported this transfer in some cases. So I get a lot of sick patients who come to me for transplant assessments and lung transplantation. So these are the different ways that they can transfer. And anything beyond this, if you're looking at an NIV transfer, if you're looking at a ventilated transfer, if you're looking at an ECMO transfer, then that has to be done through an air ambulance. that cannot be done in a commercial aircraft. So using all these investigations, I don't think as a pre-flight assessment is of any use.
Thank you, Dr. Jindal. Excellent information, especially the part about, arranging hospital kind of environment where they can be taken up. Again, just short of air ambulance, because you get these patients referred for, and they are end stage patients that you are getting.
So the difference in cost is huge. An air ambulance would just say Delhi to Chennai would cost the patient somewhere close to 10 to 12 lakhs, whereas the commercial airline transfer can be done within 3 to 5 lakhs. So
I think all the airlines may not allow such kind of transfers. What you're telling, 6 seats together. Only few airlines may.
Most of the airlines
India?
do, but it has to be done at least a week or 10 days notice has to be given. Most of the airlines do.
Okay. I think next question to you only, Dr. Apar. Apart from this commercial airlines, means what are the air ambulances? You must be seeing some ECMO patient or ventilator patient coming for the transplant and other things. What are the problems faced by this patient? What are the special precautions that we should take for such patients?
So, Chandrakant, thank you for letting me continue then on to my rant. But this is the toughest of the patient groups. So I think here our assessment of the patient changes a little bit. So when we're talking about air ambulances, when we're talking about ventilated patients or transplant patients, when we're talking about ECMO transfers, so we cannot simply depend upon how breathless they are. Most of these patients are either on NIV or they're already on the ventilator or they're on very high oxygens. So we've done transfers for patients who needed about 20 liters of oxygen. So no airline in the world does transfers on high flow oxygen. That is a standard thing. So either you get transferred on NIV plus some amount of oxygen up to 6 to 8 liters of oxygen. Beyond the NIV, you get ventilated. And the standard cutoffs that most of the transfer teams use, and again, there are no guidelines to this, this is again a clinical acumen, is the PO2, the saturation, and the FiO2 that is being used while the patient is in the ICU or in the hospital. If the FiO2 is less than 50%, the patient is able to maintain a saturation of 90 and above, and the PO2 is above 100. The patient is okay for a NIV transfer. You can use a BiPAP device or you can use an advanced NIV and transfer the patient. But again, the transfer happens in an air ambulance. Now, whatever I'm talking about is in an air ambulance only. The FiO2 going up from 50% or 40%, from less than 50% to up to 60 or 70% is an indication to intubate the patient. Or the PO2 with this FiO2 of less than 100, definitely intubate the patient till the PO2 goes to above 100 in these. And usually what we see is if the PO2 is not climbing above 100 and the FiO2 goes up above 80%, irrespective of the saturation, that is an indication for an ECMO transfer. Otherwise, most of these patients develop a cardiorespiratory arrest during their transit. As the patient is ascending, that is the time when most of these patients have an issue. And typically what the physicians, the transfer physicians have seen is that the saturation drops and simultaneously the heart rate also starts dropping. They go into a bradyarrest at that point of time. And if you've not intubated, there is hardly any room on those flights to do anything at that point of time. Doing a CPR, doing an intubation sounds like a lot of heroics, sounds like a lot of bravado, but practically it is very, very difficult to do. And of course, ECMO cannot be initiated in any of such conditions. So careful assessment of these patients on ground, talking to the family, talking to the concerned doctors who are involved in the patient care at the transfer center is very essential. Appropriate steps have to be taken to make sure that the transfer happens safely. So whether an intubation is required or whether an ECMO is required has to be upfront told, and I don't think any compromise should be made in that. We should not take chances. This is not the right time to take chances for these patients, and appropriately the transfer has to be effective.
Yes, as you said rightly, all these ventilator patient or patient on NIV, these are the very critical patients, and decision to be made on the ground itself, whether there will be any benefit or not, and what are the risks involved. And definitely qualified, the medical escort should be there along with the flight with the sufficient infrastructure to manage the emergency, suction machine, whatever, this intubation tray, everything. And that's, as you said, it's also difficult in the flight to manage all these things. So that's why careful decision should be made. Now, coming to the last question to Professor SK Chhabra, sir. What are the logistics issue related to the medicines and what are the different devices that patient has to carry on the flight if the physician advise for any medicines or devices on the flight to any chronic respiratory disease patient?
We have discussed what conditions would require support. And most important, of course, is that the patient has to be sensitized and aware that things can get complicated when the patient is flying. So that awareness needs to be created. And one can, when one talks to these patients, you get an idea that this patient is going to travel or not, or they may be discussing with you. So that sensitization is very important. That whenever you are going to travel, please come and consult for a witness. Now, we have discussed that these patients may require in-flight oxygen. We have discussed the limitations of in-flight oxygen. We have discussed the POCs, which can give you up to 6 liters, the pulse devices. And most airlines permit these, and these are certified for in-flight use. Only point that airlines make is that during takeoff and landing, these equipments are not allowed because these interfere with their own communication. But these are certified. Enough batteries are required with the NIV and the nebulizers because you can run out of batteries, so that must be ensured. And then wheelchair access is something which we always advise to these patients because if they require oxygen assessment, they definitely require wheelchair access also. Then they should carry their prescription. They should take their medicines regularly, so that, and they should have a preliminary idea of self-management in case things go wrong. And ideally, they should be traveling with a person who is well versed in taking care of these patients. In the flight, you should ask for an aisle seats, preferably close to the toilet, so that minimum distance is required. And then, as far as possible, be mobile or at least do passive exercises. And then also be aware of where they are going, whether they are going to have access to medical therapy or resources there. Are they covered by insurance in the place where they are going to land? And what is the altitude where they are going to be there finally? For example, a person whom we have advised to use in-flight oxygen is going to Ladakh. That will defeat the purpose. So I would rather tell him not to go to Ladakh, because it's not only the air travel, but where you are going to land, that is also going to cause problems. So all these patients, they require discussion about these. Patient has to be equipped to deal with these emergencies, like we have discussed.
Yes, sir. So we have one question related to this from audience. It's related to height, not related to the flight air travel. A person, 75-year male, who wanted, without any comorbidity or respiratory disease, wanted to go to at the altitude of 20,000 feet, some Pangong Lake kind of thing. This question is from Dr. Keval Bansal from Telangana. What is your take on that, sir?
A person who is 75 years old, his PaO2 would, in any case, because PaO2, that also decreases with age. Our alveolar arterial difference increases with age. So this patient would have saturation around 91, 92%.
Yes, sir.
It would be around 70. So his reserve is already exhausted. Now, if he climbs to 20,000 feet, and we have discussed that the atmospheric pressure will go down drastically to 20,000. So at that point, his alveolar oxygen will further decline. So he is going to go into respiratory. So this is absolutely contraindicated. In fact, 20,000 is too high. I get requests from these patients to travel to Badrinath or Kedarnath, which is at 3,500 meters. And I tell them, no.
Yes.
You have gone when you were young. Now it's too late. So these limitations are there because of physics of atmosphere and because of their own pathophysiology. So
Yes,
when clearly, no, they must be warned not to undertake, because we hear patients dying while on Kedarnath Yatra or in Badrinath. So all these are preventable deaths, provided they are taken assessment. But then patients don't come to the doctors for certification. And our travel regulations, unfortunately, do not require you to carry. But now these things are getting, more recognized, and I believe this will become more in use later.
So we have a couple of questions from the audience. One question from Dr. S. Jayaraman from Tamil Nadu. Is it safer to fly with the patient with the bulla?
Again, the issue of expansion is their size of bulla is important. And a big bulla, there is a risk of expansion, a theoretical risk of pneumothorax is there. So, but that is not listed as a contraindication. So we can talk to the patient, advise him not to travel, seek advice for possible treatment of the condition. So that is resolved, because this risk is going to be there till the bulla is there. So big bulla becomes a relative contraindication, and that should be attended to while he's on ground, so that risk is eliminated.
Sorry, I'm bombarding with you only with the questions. One more question is related to this, related to height only. For helicopter, it is from Dr. Harpreet Kaur from Ludhiana. Is helicopter flight is safe for COPD patients?
See, fortunately, helicopters don't go to that height. So they're not pressurized. So that much decline in pressure one can tolerate. So that is not an issue, provided one is clinically stable, saturation is above 95. Like we said, in general, any acute exacerbation of asthma, COPD, thoracic surgery in last 4 to 6 weeks becomes the contraindication. A saturation, clinical stability, a good 6-minute walk test, one is certified as fit to.
Yes, sir. There is one more question. I think I will answer that question. This is from Dr. Suraj Maldat from the Maharashtra Latur. He's asking regarding anxiety, hyperventilatory tetanic episode in the flight, not getting better with the counseling. How to manage this? I think in such patient, sir, I think anxiolytic, if it's available in the flight with the patient, I think normally flight, I think crew may not be carrying the anxiolytic with them. So I think if it is available to the patient, I think we can use that, some clonazepam or something if they are having with them.
But Chandrakant, anxiolytics are always available on board.
Oh, okay, that's okay.
The airlines always have a medical box in which there is a large multitude of medicines available, and even emergency drugs like atropine and adrenaline is available over there with IV infusions, IV syringes, all those things. Only thing that is required is a registered medical practitioner has to be present on board for the crew to be able to open it. It's a locked thing. It's a sealed box. For them to be able to open it, you need to have a registered medical practitioner on board who has advised them and later will sign a form saying that why did he advise that and what was used and how it was used. Yes. So I think this is part of the Good Samaritan effect, that if you are on board, you can help the patient, you can have access to those, there is simple medical equipment. There's a stethoscope, there's a BP apparatus on, inside that box. And there are few medications that
are also there now.
I think we have covered most of the questions and almost all the aspects related to the air travel. Now, coming to nutshell, I think, so I will try to summarize as this Chhabra sir explained everything. With the air travel, partial pressure oxygen drops and cabin will be pressurized to maintain the oxygen level somewhere around 8,000 feet, and it will be around 15% if you consider. And persons with the special severe disease can face the problem. Special situation, they can face the problem. We should be ready for it. And all the such patients should be optimized before the air travel. Whatever the diseases are, whether it's COPD, asthma, whether the patient underwent surgery, we should optimize them. And related to infection, not only for the patient, for the fellow passenger, we should consider and we should advise them when to travel. And considering to the ECMO patient, ventilator patient, already Dr. Apar Jindal has explained, they should be evaluated on ground itself, and if necessary only they should be carried to different cities and with the proper trained medical escort. And as you said, the discuss in the last, this is a general message for every doctor who is listening this webinar. Is there a call from the crew attendant, whether there is a doctor in the flight? I think we should come forward. And already we have listened and we have learned everything related to how to manage this emergency. I think we can help the cabin crew for managing these emergencies. I think now we can take some concluding remarks if anybody have, or especially from the Dr. Chhabra sir.
You have summarized it very well, and it was an excellent discussion. I learned a lot, and thank you, Dr. Jindal, for very good information, especially in the patients who require transport in special circumstances. Now, one thing that just one small message. We have heard a lot about SCT. we should not bother if the service is not this is something which guidelines do mention, but good clinical acumen, good history examination, simple tools like spirometry and pulse oximetry, blood oxygen if available, ABG, and that's usually easily available. So that is more than sufficient to decide whether patient requires in-flight oxygen, in-flight support. So even if HCT facility is not there, which majority of centers in India will not have, so don't worry too much about that.
Okay, Dr. Apar, you want to add something?
So I think it's been summed up beautifully, and I totally agree with what Dr. Chhabra is saying, that let's not bother about what we don't have. Let's make use of what we have to make sure that our patients are able to travel safely. And yes, like we were talking about it, Chandrakant, during a pre-webinar meeting also, I think that is a message that I would again like to reiterate, that maybe Dr. Chhabra can spearhead this, but rather than just relying on the BTS guidelines, it is time that we at least come up with our recommendations, if not guidelines, as to how we can cater to our patients in a uniform manner in our country. And that can also serve as an advisory to the regulatory bodies, as you've been mentioning.
I think it's already now 10 p.m. We'll not take any further this thing. Already everything is well summarized by Dr. Apar Jindal and Dr. Chhabra, sir. Now I thank all the panelists, Professor SK Chhabra, sir, for excellent talk and all answering all the queries. Dr. Apar Jindal, Dr. Keerat Kaur, Dr. Narendra Kumar, and Dr. Jainam. Now also I want to thank Professor Dr. Ashish Dubey, who is the National President CCI, Dr. Anil Maske, Dr. N.H. Krishna, who is the founder president of our CCI, Dr. Narayana Pradipa, and more importantly, Dr. Atri, Dr. C. Vijay Kumar, sir, who are backbones for this webinar team. And also I thank our webinar partner Cipla team for organizing this. And I thank all the audience who stayed here for almost 2 hours to support us and we are listened us. Thank you. Thank you, all of you. Thank you very much.
Thank you very much, and good night, everyone.
Thank you, everyone.
Good night.
Good night.
Good night.
Thank you.